Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everybody. I would like to welcome you back to my educational channel. Today's presentation we are going to talk about the pharmacological profile of specific tricyclic antidepressants. In my last presentation, we talked about the different types of depression, mental depression. We talked about the mechanism of action of antidepressant and how most of them they act by increasing the availability of the monoamine at the synapse, and this, as we have discussed, will result in adaptive changes in the sensitivity of the presynaptic and postsynaptic receptors. We said that all antidepressants they act through the monoamine system, and we classify them into four major groups. The first were the tricyclic antidepressant, then the selective serotonin uptake inhibitors, then the monoamine oxidase inhibitors, and the atypical antidepressant. In today's presentation, inshallah, we are going to discuss the pharmacological profile of the famous tricyclic antidepressant, and this will include their mechanism of action by inhibiting the monoamine reuptake, as we will discuss in details, their anticholinergic action, their sedative action, and their cardiotoxicity. We are going to discuss as well their clinical application or the application of tricyclic antidepressants and when they are contraindicated. Lastly, we'll talk about their overdose toxicity and how it is treated. So this class of drugs, actually, they are very important because it contains a lot of basic pharmacology that we will discuss in a few minutes. So what are the tricyclic antidepressants? What are the tricyclic antidepressants? They were drugs which were introduced in the late 1950s, and they have a tricyclic structure. As you can see, this is the tricyclic structure of the prototype imipramine, as you will see later, okay? Yeah, but they are known as tricyclic because they have a tricyclic structure. They are, of course, second choice in the treatment of mental depression, as we will see later, and as well they have other clinical application. So we'll speak about the pharmacological profile of this important group of drugs. First, we'll talk about their kinetics, not in details, of course, but the most important information about their kinetics. They are exposed to first-pass metabolism by the effect of cytochrome B450, and these will usually, there are not all of them, but most of them, they are metabolized to active metabolite. That means they act as prodrugs. They are active and they are metabolized to another active antidepressant. Usually, they have relatively long half-life time, which ranges from 8 to 24 hours, and that's why they are used only once a day. The dose is once a day, which is, of course, convenient to the patient. Also, they are secreted through the kidney. So, therefore, they are metabolized in the liver, and their metabolites are excreted mostly through the kidney. This is important for us in cases where there is a liver disease or kidney disease or in old people or geriatrics, because in this case, they will accumulate and they might produce toxic effects. These drugs, they have different mechanisms of actions. That's why they are known as dirty drugs. Why they are known as dirty drugs? Because they will act on different receptors. They are as the blockers on different receptors, and as well as the blockers to different ion channels, as you will see later. And they are not selective in their action. They can block different receptors and they can block different ion channels. That's why they are known as dirty drugs, and we expect, therefore, that they will have many side effects because, as we have said several times, in action, some of them, they are desirable and they are considered to be therapeutic application or therapeutic use, and the other actions, there are side effects. Some of them are so dangerous that they might become a contraindication. So these drugs, they will inhibit monoamine reuptake, as you will see. As we have discussed several times before, monoamines, they are stored in the nerve terminal and they will be released upon an action potential at the nerve terminal. They will act on either postsynaptic or presynaptic receptor, and then they are reuptaken again into the nerve terminal. This is how their action is terminated, by reuptake into the nerve terminal. The monoamines, of course, they include 5-hydroxytryptamine, dopamine, and adrenaline and noradrenaline. 5-HT and noradrenaline, they are responsible for the antidepressant effect. Therefore, by inhibiting reuptake, the availability of the monoamine at the synapse will be increased. It will stay longer in the synapse, and this, as we have said before, will affect the auto and hetero receptors on the nerve terminal, and this will result in the long term in an increase in the aminergic activity. Yep, this is the first. They act by inhibiting monoamine uptake. This will result, if it happens centrally, this will result in antidepressant activity. Antidepressant activity. Yep, their antidepressant effect is related to their inhibition of the monoamine reuptake. The second, these drugs, they are known as dirty drugs because they have anticholinergic effect. Anticholinergic effect. Well, anticholinergic, as we have discussed several times before, means that they block muscarinic receptors. Block muscarinic receptors. اللي هم الاسيتايلكولين receptors. By blocking the muscarinic receptors in the exocrine glands, they will produce dry mouth, for example. They produce dry mouth, which is usually, this is a side effect. They can block a muscarinic receptor on the salivary gland, producing dry mouth. Also, they can block a muscarinic receptor in the pupil of the eye, producing mydriasis and failure to accommodate for near vision. These mydriasis will result in what's known as blurred vision. Vision will become blurred, not clear. Also, they can block muscarinic receptor on several smooth muscles, like smooth muscle of the intestine, and this will result in constipation. This will result in constipation, as we know. Also, they can block the muscarinic receptor in the urinary tract, and this will result in urinary retention. Urinary retention. All these, of course, they are side effect. All of them, they are side effect. And all of this is known as atropine-like action. Atropine-like action or antimuscarinic effect. These drugs as well, they can block the histamine H1 receptor, histamine type 1 receptor. And this usually results in sedation. Some of these drugs, they can produce sedation by blocking the H1 receptor in the central nervous system. As we know, blocking the H1 receptors in the brain will result in sedation. More than that, these drugs, they can block the alpha-1 adrenergic receptor. Well, alpha-1 adrenergic receptor, as we know, they are present in a lot of places, including the resistance blood vessels. Resistance blood vessels like arterioles. This will result, resistance blood vessels like arterioles, this will result in vasodilatation. Vasodilatation. And this vasodilatation will result in decrease in blood pressure, especially after changing the posture. Especially after changing the posture. When the person is in lay down position and he changes his posture to the upright position, this will lead to what's known orthostatic hypotension. Orthostatic hypotension. These drugs, as you can see, they can produce several side effects due to blocking of different adrenergic and cholinergic receptors. Okay? This is their mechanism of action and the expected side effects and therapeutic effect. These drugs as well, they are known of reducing cardiovascular toxicity. they can produce cardiac toxicity. And therefore they can produce different types of arrhythmias. Arrhythmia اللي هو disturbance in the rhythm of the heart. As we know, the heart works in a rhythm fashion. If the rhythm is affected, that means the heart will suffer from cardiac arrhythmia. Well, cardiac arrhythmias are dangerous because they will result in, at the end, in decrease in cardiac output, and they can produce several bad effects. So how they can produce these different kinds of arrhythmia? What are the toxic effects on the cardiovascular system? First, by blocking the muscarinic receptor in the heart, these drugs, they can increase the heart rate. They can increase the heart rate. طبعا this is dangerous, especially in the people who are suffering from ischemic heart disease. This is anticholinergic effect. By blocking muscarinic receptor and SA node will result in an increase in heart rate. And here tachycardia is known as tachycardia. Okay? Tachycardia. This is one. Also, these drugs, they can block the alpha-1 receptor, as we have said, alpha-1 receptor on the blood vessels, which will result in peripheral vasodilatation and pooling of the blood in the periphery. When the person changes his posture, he will suffer from orthostatic hypotension. Orthostatic hypotension, which is not a nice feeling. Also, they inhibit noradrenaline uptake in the myocardial cell. معناها will increase the availability of noradrenaline. In this case, will increase the contractility of the heart muscle. ما دام الcontraction is increased, increase the contractility means increasing the oxygen demand. Increasing the oxygen demand. This is dangerous, especially in the ischemic heart disease. لما person is suffering from ischemic heart disease, like an angina pectoris or myocardial infarction, these drugs, they can increase the symptoms or increase the severity of the ischemic heart disease. Of course, this would be a contraindication. Also, these drugs, they block sodium channels. They block sodium channels in the myocardium. This is most important. You have these drugs, when they are dirty, because they block receptors, and as well they block ion channels. The first ion channel we are talked about, but they block sodium channels. They block sodium channels in myocardium. When they block sodium channels, this is a depression of the myocardium. These drugs, by blocking sodium channels, they prolong the QRS complex. They prolong the QRS complex, QRS, which is actually the depolarization of the ventricle, which is the systole. Systole, as we know, لما the excitation reaches the ventricle, it will contract. This contraction of the ventricle will result in cardiac output, which is known as systole. Therefore, by prolongation of the QRS complex, this will result in arrhythmia. خلل في النظم. Arrhythmia. And this result in arrhythmia, disturbance in the rhythm, will decrease the cardiac output. So what will happen to the patient when the cardiac output is decreased? What will happen to the patient? He will feel dizziness, of course. Dizziness لأن there is no enough blood reaching the brain. For the patient will feel dizziness, will feel fatigue all the time, even after small exercise, and also exercise intolerance. These are very bad consequences. So sometimes this decrease in cardiac output will result in sudden cardiac death. Therefore, TCA or tricyclic antidepressant, by blocking sodium channels in the myocardium, they will increase or prolong the QRS complex, which represents the depolarization of the ventricle. Depolarization means contraction of the ventricle, which is the systole, and this will result in decrease in cardiac output, and the decrease of cardiac output, the patient will feel it as a dizziness, fatigue, and exercise intolerance. Sometimes this will result in cardiac death. Not only that, tricyclic antidepressant, they can block the potassium channel in the cardiac muscle. They can block potassium channel in the cardiac muscle. This will result as well in prolongation of the QT interval. This is the QT interval. By blocking potassium channel, QT interval would be prolonged. This will produce potential dangerous arrhythmia called as Torsades de point. Torsades de point, which is very dangerous and can lead to ventricular fibrillation. It leads to ventricular fibrillation, and this ventricular fibrillation will result in severe decrease in cardiac output, which can result in cardiogenic shock and sudden death. Therefore, tricyclic antidepressant, by blocking potassium channel in the myocardium, they lead to prolongation of the QT interval, and this will result in dangerous Torsades de point, which means ventricular fibrillation that might end up in sudden death. These are the cardiac toxicity of tricyclic antidepressant. They can produce different types of arrhythmia because of different action on the receptors and the ion channels in the myocardium. Okay. These are the pharmacological profile of the tricyclic antidepressant. So how they differ? Tricyclic antidepressants, are they the same or they are different from each other? They differ. The first difference, they differ in the time of their introduction. For some of them, the early tricyclic antidepressant, they are more toxic than the second generation antidepressant. So we have a first generation antidepressant, tricyclic antidepressant, and we have the second generation tricyclic antidepressant. Usually these were discovered before the 1960, and these they were discovered after the 1960. طبعا the second generation, they were introduced by changing the chemical structures in the first generation to obtain a tricyclic antidepressant with less toxicity and less side effects. Also, the tricyclic antidepressant, they differ in the type of monoamine they inhibit, monoamine reuptake inhibition. For some of them, they inhibit the 5-HT and noradrenaline together. They are non-selective. They inhibit the uptake of 5-hydroxytryptamine and as well noradrenaline. And some of them, they are selective in inhibiting noradrenaline. Of course, they will differ in their anticholinergic, severity of anticholinergic effects اللي ذكرناها, including blurred vision, constipation, urinary retention, etc. Some of them, they have a strong anticholinergic effect. Some of them, they have moderate to weak anticholinergic effect. Some of them, they are different in their sedative effect, and they are different in their cardiotoxicity, which we talked about. So let us make a table to make it easier for us to understand what is the differences between different tricyclic antidepressants. We start with the first generation antidepressant. As we said, they differ in selectivity, they differ in their kinetics, they differ in the anticholinergic action, they differ in their sedative effect and the cardiotoxicity. The prototype of the first generation is imipramine. Imipramine. We never forget imipramine. Imipramine. This is the prototype tricyclic antidepressant. It is most famous of the tricyclic antidepressant. Usually comparison is made according to the imipramine. Imipramine is non-selective in its uptake of monoamines. It inhibits both uptake of 5-hydroxytryptamine and noradrenaline. The second is amitriptyline. Amitriptyline which is like imipramine. It's non-selective. It inhibits both monoamines, 5-hydroxytryptamine, and noradrenaline. Dizibramine, which is actually a metabolite of imipramine. Dizibramine is the metabolite of imipramine. It acts selectively on noradrenaline. The same thing for nortriptyline. Then we have dizibramine or nortriptyline. They are the active metabolite, and they act by inhibiting the reuptake of noradrenaline. Lastly, cloimipramine. It's selective for 5-hydroxytryptamine. The cloimipramine blocks only 5-hydroxytryptamine uptake, which is serotonin uptake. Okay. Now, imipramine kinetically it is a prodrug. It is metabolized to active metabolite. It is metabolized to dizibramine. In this case, we'll have an active drug and active metabolite. You have the imipramine is metabolized to active. The same thing with amitriptyline. It is metabolized to nortriptyline. It is active metabolite. If the dizibramine is the active metabolite of imipramine, while nortriptyline is the active metabolite of amitriptyline. Okay, so these are the kinetics of the tricyclic antidepressant. Anticholinergic, these are the first generation. Therefore, you expect they will have a strong anticholinergic, especially the prodrugs. We see that take it as a principle that the prodrugs take it as a principle that the prodrugs usually they have a strong anticholinergic effect, while the metabolites they have weak anticholinergic effect, as you can see. The first generation, which one will have the strong anticholinergic effect? اللي هم urinary retention, constipation, blurred vision, all what we have discussed. Imipramine, first generation, the prodrugs, whether it is imipramine or amitriptyline. While the metabolite, their active metabolite, they have a weak anticholinergic effect. Cloimipramine, it has moderate anticholinergic effect. The same thing for the sedative effect. The prodrugs, they have a strong sedative effect, while their metabolites, they have a weak sedative effect. Clomipramine, it has a moderate sedative effect. Cardiotoxicity, the same thing. The prodrugs, they have a strong cardiotoxicity. They produce different types of arrhythmias and contraindication, while their metabolites, they are less toxic. Okay. On the other hand, cloimipramine is the highest toxicity on the heart. It has the highest cardiac toxicity. These are the first generation tricyclic antidepressants. After that, they have introduced many drugs which are known as the second generation tricyclic antidepressant, in the hope that this group of drugs they will have less dangerous side effects. So the very first introduced was doxepin. Doxepin is famous. It is non-selective in blocking. It blocks both 5-hydroxytryptamine and noradrenaline. Amoxapine, it is non-selective in blocking the monoamine, and as well it blocks, this is very characteristic for amoxapine, it can block D2 receptors, and as we have said before, blocking dopamine type 2 receptors will result in antipsychotic effect. Amoxapine, it inhibits the monoamine uptake, and as well it blocks the D2 receptors. That's why it is applied in the treatment of depression and as well as antipsychotic. It will be a very effective tool in patients who are suffering from both mental disorders, psychosis and depression. Maproteline, it is noradrenaline selective. Triimipramine is non-selective for both 5-HT and noradrenaline. Lofipramine is non-selective. If the most second generation, they are non-selective. The things that we should remember in an amoxapine, It can block D2 receptors as well, and it has certain application in the treatment of psychosis mixed with depressive disorders. The kinetic, all of them, they are metabolized to active metabolite, all of them. That means they will have a long duration, long pharmacological duration of action, because themselves they are active, themselves they are prodrugs, and they are metabolized to active metabolite. The pharmacological duration of action will be extended. These drugs usually they have moderate anticholinergic effect. They have moderate anticholinergic effect, but they have a strong sedative effect. As you can see, doxabine, mebufotenin, and triimibramine, they have a strong sedative effect. That's why doxabine sometimes it is applied in treatment of insomnia. Cardiac toxicity, they are less toxic than the first generation tricyclic antidepressant, except for the triimibramine. These are the second generation. Second generation, as I have said, they mostly they are non-selective. All of them they are metabolized to active metabolites. They are moderate in their anticholinergic side effects. They have a strong sedative action, and they have less cardiac toxicity than the first generation tricyclic antidepressant. So what are the clinical applications of these drugs, tricyclic antidepressants? In clinical application, first, they are used in treatment of major depressive disorders, which we have discussed in last presentation. And in this case, they are used as second choice, not first choice. If the first choice that we are going to talk about in the next presentation, selective serotonin reuptake inhibitors, if they are not effective, i.e. the patient, there is a resistance to the selective serotonin uptake inhibitors like fluoxetine and its like. In this case, we can use the tricyclic antidepressant. The most commonly used is imipramine, amitriptyline, nortriptyline, and dizipramine. Also, these drugs they are used as in anxiety disorders. In anxiety disorders, especially panic attack, which is a severe attack of fear, sudden feeling of severe fear, خوف. Severe attack of fear. Also, they are used in the obsessive compulsive disorder. Which is obsessive compulsive disorder, or OCD, which is a form of anxiety in which the person will repeat certain behavior many times, like washing of hands, etc. This is known as obsessive compulsive disorder. You have the imipramine and cloimipramine. They have off-label use in the treatment of panic attack and obsessive compulsive disorder. Next, clinical use, they are used in treatment of insomnia. Certain types of insomnia with depression underlying, the underlying cause is depression. Usually we give tricyclic antidepressant with strong sedative action, like doxabine. And these should not be used for a long period of time. They're only used for a short period of time, okay? They must be used under very close medical supervision. Also, they are applied as an adjuvant in treatment of pain. Adjuvants, that means they are given with other analgesics, drugs which are used. They are used with other analgesics for the treatment of certain types of pain. Like, for example, neuropathic pain. Neuropathic pain, the pain which results from a damage of the neuron, like neuropathy which results from diabetes mellitus. some people, after long exposure to diabetes, they will suffer from pain in the periphery due to neuropathy. Okay. Also, in other types of neuropathic pains, like trigeminal neuralgia or spinal cord injury. Also, they are used as adjuvant to analgesics in treatment of different types of chronic pain syndrome. Chronic pain syndrome, like for example, fibromyalgia. Fibro, which is pain in the skeletal muscle and the fibrous tissue. Fibromyalgia. وكذلك they are used in the treatment of pain due to chronic tension. Chronic tension. In this case, the most commonly used are the amitriptyline and nortriptyline. Amitriptyline. This is very important clinical application of tricyclic antidepressants. They are used for neuropathic pain, and as well they are used for chronic pain syndrome. Next application, they are used in nocturnal enuresis, which is the bedwetting by children at night. Why they reduce bedwetting? Because they have anticholinergic effect. They produce urinary retention. And the most commonly used is imipramine and desipramine. Of course, this use should be done under very close medical supervision. Next use is in the treatment of attention deficit hyperactivity disorder, which is known as ADHD, especially in adults. Of course, this disorder is a psychological disorder in which the person is hyperactive with less concentration. Yet in this case, desipramine and imipramine have been used, have an off-label use, of course. Okay, yep, these are the clinical application of TCA. As we can see, they have many clinical application, whether they are approved or off-label use. We, as a medical profession, we have to know about these uses and we have to know about their contraindications. So these are the clinical application. Next, we're going to talk about their contraindication, when we should never use tricyclic antidepressant. Of course, there are many reasons. There are many causes. The first, we should never use them in a patient suffering from cardiovascular diseases, like in cases of ischemic heart disease or arrhythmia or conduction defects. Yani if the patient is suffering from any defect in cardiovascular system, especially ischemic heart disease like a myocardial infarction or angina, or he is suffering from arrhythmia or conduction defect, he should not be given TCA, because as we have said, they will affect the they will affect the rhythm of the heart, as we have explained earlier. Next, they should never be used in neurological condition, like patients suffering from epilepsy, SARA. They have found that TCA, they increase the severity of epilepsy, and as well as SARA, epilepsy SARA, they increase the severity of epilepsy. كذلك should not be used in cases of head trauma or increase in intracranial pressure. Of course, they should not be used in people suffering from glaucoma, because these drugs, they will increase the intraocular pressure. TCA, قلنا what they do, they produce mydriasis. والmydriasis, of course, will increase the intraocular pressure. It will make the glaucoma worse. Therefore, they should not be given to a patient suffering from closed-angle glaucoma. Also, they produce anticholinergic effect, they produce urinary retention. Therefore, they should be avoided in patients suffering from prostatic hypertrophy. Usually, for prostatic hypertrophy, the prostate gland, it will block the flow of urine. The prostate gland is enlarged, it will block the flow of urine. And if the TCA themselves, they produce urinary retention, the person will suffer more. Therefore, they should not be used in cases of prostatic hypertrophy. Of course, they should never be used, they should not be given, they are contraindicated in liver or kidney diseases. If the patient is suffering from liver or kidney diseases, we have explained why, because they are metabolized in the liver and they are excreted through the kidney. If we give these drugs, they will accumulate in the body and this will lead to toxicity. They should be avoided in elderly patient, old people. Why? لأن elderly patient they have low metabolic enzymes, معناها they will metabolize the drug slowly, and as well they have low renal function, معناها the excretion of the drug will be delayed. Also, they should not be given in pregnancy and breastfeeding. They should not be given in pregnancy and breastfeeding. Why? لأن في البريجنانسي tricyclic can pass the placenta and can reach the fetus, can affect the fetus. And breastfeeding, because they will be excreted in the milk, therefore should not be given in pregnancy and breastfeeding. Lastly, these drugs, they should never be mixed with monoamine oxidase inhibitors. They should never be given in a mixture with monoamine oxidase inhibitor. Why? Because they can produce to severe increase in blood pressure and they can produce hypertensive crisis, as we will explain inshallah in our next presentation. Okay, يبدأ these drugs, TCA, tricyclic antidepressant, they should never be given together with monoamine oxidase inhibitors. يبدأ these drugs, as we can see, they have many contraindication, and we as a medical profession, we have to know when to use these drugs. Lastly, these drugs, they are toxic. In overdose, they can be highly toxic. They have a narrow therapeutic index. And with therapeutic index, we have explained before, is the difference between the therapeutic dose and the toxic dose. This is known as therapeutic index. فكل ما therapeutic index يكون large معناها the drug is safe. كل ما therapeutic index is small معناها drug is not safe. معناها in this case, if we increase the dose only 10 times, the person might suffer from acute toxicity, which is life threatening. Therefore, in this case, as an advice, never give many number of doses to a patient with depression. Then a patient with depression, usually they have suicidal ideas. Sometimes he is exposed to suicidal thinking, and by taking only 10 tablets, he can enter into a toxic dose, fatal toxic dose. So what are the symptoms? Of toxicity? As we have explained before, symptoms of toxicity including an anticholinergic effect, which is the blurred vision, the constipation, the urinary retention, etc. Also, they can produce cardiovascular effect, including the different types of arrhythmia, the QRS prolongation, and the QT prolongation, which can result in different types of arrhythmias. Also, they can affect the central nervous system, and they can produce seizure. Or convulsions. Seizures اللي هو الاختلاجات or convulsions. Also, these drugs, they can depress respiration and they can produce hyperthermia. Toxic effect can produce hyperthermia. Yet these drugs, they are highly toxic, and this is one of the reasons why they are not commonly used, because they have a narrow therapeutic index. Only about 10 times the therapeutic dose can produce toxicity symptoms which are very dangerous. So how we can treat this overdose toxicity? How we can treat it? Usually treatment, as we know, it's done in ICU. It should be a supportive measures first in ICU to treat the patient according to his symptoms. First thing, priority is given to airway management. If there is respiratory depression, the patient should be put under artificial respiration with oxygenation and ventilatory support. Anticholinergic side effects can be treated with physostigmine. Physohystamine, as we have discussed before, is anticholinesterase. It will increase acetylcholine peripherally and centrally. It will antagonize the anticholinergic effect of TCA. Like this should be done with caution. Why? An excessive physohystamine can produce excessive cholinergic activity. The cardiovascular effect usually اللي هم الارrhythmia, especially the most dangerous arrhythmia. Arrhythmia is corrected by sodium bicarbonate, which is used for the widening QRS complex, and lidocaine, which is used in cases of Torsade's depoint. Okay, the cardiovascular effect can be treated with sodium bicarbonate and other antiarrhythmic drugs like lidocaine. Lidocaine is a local anesthetic. It is a local anesthetic. The central nervous system effects can be treated, especially seizures or convulsion. Seizures or convulsions, they are treated with intravenous diazepam and lorazepam. The hyperthermia can be treated with cooling measures like the use of ice. Cooling measures for the hyperthermia should be done, of course, in the intensive care unit. And hyperthermia is very dangerous. If the person just ingested or taken the overdose in less than 1 hour, in this case we can give activated charcoal. And activated charcoal given orally طبعا. Activated charcoal will absorb the TCA in the stomach and prevent their systemic absorption. And this is done only if the ingestion is recent. If the person who took the overdose, he took it for less than 1 hour. This activated charcoal will prevent further absorption of the tricyclic antidepressant. So these are the pharmacological profile of tricyclic antidepressant. We can summarize our talk that there are 2 generations. Second generation, usually they are less in severity of side effects. They are dirty drugs. Why? Because they block multiple receptors, like in muscarinic receptor, like an H1 receptor and alpha-1 receptor. Also, they can block sodium channel and potassium channel, which will result in different types of arrhythmia, which are dangerous. Also, we talked about their clinical application and clinical consideration, where they are used in several clinical situations. We talked about their therapeutic index, how they have a small therapeutic index, and how an overdose can produce severe toxicity, which can result in mortality. We talked as well about the treatment and how it is done in the intensive care unit. In this case, we have said that it is supportive and drugs are used as appropriate. By this, I have finished my presentation with you today. I will say thank you very much for your attention. I hope to see you again in my next presentation. And we end up with the الآية الكريمة وفي أنفسكم أفلا تبصرون. صدق الله العظيم. شكرا لكم على حسن الاستماع. الرجاء لا تنسوا الاشتراك في القناة، الإعجاب، التعليق والمشاركة مع الزملاء. دمتم بخير وعافية، والسلام عليكم ورحمة الله.